our mandate, which is the UN Working Group on Discrimination Against Women and Girls, it was established back in 2010. So we're nearly 11 years old. And the mandate was established probably following the tireless efforts of civil society, member states, and other actors who recognised that despite progress on discrimination against women and girls, in 2010, persisting across the world was continuing discrimination. It transcended national, cultural, and religious barriers. And fortunately, at that time, the Human Rights Council saw fit to create the UN Working Group on Discrimination Against Women and Girls. We form part of a special procedures division of the UN. We are, together with the Special Rapporteur on Violence Against Women and Girls, we are the only two mandates out of 44 thematic mandates which focus on women's human rights. And that's despite the fact that women represent over half the world's population. And not only that, they continue to face many barriers in achieving full equality. We have a number of working methods, really three main methods. One is the creation of annual thematic reports, and you'll hear from my colleague Melissa Upreti on the thematic report that we have recently submitted to the Human Rights Council. We go on country visits, although of course over the last 18 months the UN country visit program has been suspended, but we have done around 20 country visits, and we issue official communications. And in the life of the working group, we've issued around 450 official communications to nation states on alleged violations of women's human rights. We also act as amicus curiae, as a friend of a court in different court proceedings, and we will be acting in a Supreme Court proceeding in the role of amicus curiae coming up in the next month or so, and Melissa can tell you about that. And we also develop position papers to extend some of the thinking, particularly in new areas, and there we'd be talking about surrogacy and other areas, men's accountability for women's human rights as well. And over the last 10 years, we have engaged extensively in the Asia Pacific region. It's such an important region, and we've used each of our working methods to do that.
The opportunity to work in partnership with the UN Working Group on the critical issue of women and girls' reproductive and health rights is very much in line with the APF's strategic objective of gender equality. NHRIs are critical to promoting and protecting human rights at the national level, but we also have a recognised role to engage at the international level, including with UN agencies and special procedures, including the UN Working Group. A number of our NHRIs have promoted the rights of women and girls in relation to reproductive rights. The APF has previously collaborated with the UN Population Fund, UNFPA, in a study on reproductive rights, and a workshop held between APF members and UNFPA country officers. We continue to look at further collaboration with UNFPA to support our member institutions.
I will first present on the Working Group's new thematic report titled Women's and Girls' Sexual and Reproductive Health Rights in Crisis, which was presented to the Human Rights Council in June. Now, in this report, the working group examined key factors and trends that undermine and threaten the sexual and reproductive health and autonomy of women and girls before and during a crisis. These factors are underpinned and exacerbated by various forms of systemic disadvantage and structural discrimination that women and girls face throughout their lives. The report identifies the non-enjoyment of women's and girls' sexual and reproductive health rights as a crisis in itself and emphasizes the need for a radical shift in how situations of crisis are identified and addressed. What we highlight in the report is that a crisis is often defined as an event or a series of events representing a critical threat to the health, safety, security, and well-being of a community or other large group of people. In this thematic report, we emphasize that the focus on an event in the understanding of a situation of crisis may divert attention from key underlying factors that make a given situation critical for different populations, especially for women and girls. If the focus is strictly placed on a sudden event or a series of events as the defining elements of a crisis, the gendered impact risks not being fully understood and addressed. We note that gender inequality itself is viewed by many women around the world as a crisis. Similarly, women and girls have identified the widespread occurrence of forced and early pregnancy, whether caused by sexual abuse or harmful practices such as child marriage, as a serious crisis. Now, while many sexual and reproductive health harms are experienced in the form of a personal crisis, the causes are often systemic and linked to structural discrimination. Consequently, there is an urgent need for a radical shift in the approach to understanding and dealing with crises, which must be gender responsive and intersectional, and acknowledge the hidden trauma and lifelong, as well as the intergenerational consequences associated with the non-fulfillment of women's and girls' sexual and reproductive health rights. Now, women and girls' sexual and reproductive health rights are clearly established under international law. Yet, an estimated 810 maternal deaths occur each day, and annually there are 25 million unsafe abortions, resulting in approximately 47,000 deaths, primarily in developing countries and among women living in poverty. Every 16 seconds, there's a stillbirth. Every 16 seconds. More than 200 million women who want to avoid pregnancy are not able to use modern contraception. Millions of women and girls do not have the means to manage their monthly menstrual cycle safely and with dignity. Now, the situation only gets worse when a crisis event occurs. So we have identified multiple factors that underlie and exacerbate the risks and threats to women's and girls' sexual and reproductive health rights. And these include discriminatory laws, policies, and practices, which predispose women and girls to a much higher level of vulnerability. Failure by states to prioritize sexual and reproductive health rights. Lack of investment, financial investment in sexual and reproductive health services. The lack of legal accountability for violations of human rights associated with the denial of access to sexual and reproductive health services. Lack of support for feminist and women's rights organizations and violence against women human rights defenders. The exclusion of women and girls from decision-making processes. The lack of engagement and accountability of men and male allies. And finally, the ideological and religious opposition to sexual and reproductive health rights. Now, while these factors pose significant challenges, crisis-related events can trigger additional challenges. So health systems that are already deficient in the provision of essential sexual and reproductive health services often struggle with the collapse of health infrastructure. Financial and human resources are diverted away from the provision of sexual and reproductive health services. During the last year and a half, after COVID hit, some countries have actually restricted access to specific reproductive health services, deeming them non-essential. We also note with concern in our report that the priorities of donors often drive interventions in situations of humanitarian crisis, and gender equality is not always a primary concern. The needs of adolescent girls, access to safe abortion, are especially neglected. We also note in our report that there are women and girls facing compounded barriers and threats due to multiple and intersecting forms of discrimination, such as, for example, those living with disabilities, residing in rural areas, migrant, refugee, and internally displaced women and girls, and specifically adolescent girls. Further, in our report, we identified groups of women and girls who have been living in what we describe as, quote unquote, a persistent state of crisis, as a consequence of a history of oppression, exclusion, and discrimination, as well as systematic violence and disregard for their culture, spirituality, and tradition. We refer in particular to Indigenous women and girls of African descent, and Roma women and girls as examples, although there are many more subgroups. Now, we recognize that certain crisis events cannot be prevented, but states can be better prepared to deal with them. And we have identified 5 interrelated sets of actions to enable progress towards ensuring the protection and fulfillment of sexual and reproductive health rights of women and girls at all times. And in our report, we present recommendations and have urged member states to, first of all, prioritize sexual and reproductive health and rights in law, policy, and practice. Second, eliminate discriminatory laws, policies, and practices that predispose women and girls to being more vulnerable during the crisis. Third, institutionalize and strengthen monitoring and accountability for violations in sexual and reproductive health rights. Fourth, ensure women's and girls' participation in decision-making processes while promoting male accountability. And fifth, push back against conservative and anti-human rights ideologies. In conclusion, I'd like to note that we do see a very important role for national human rights institutions as a bridge to promote the implementation of the recommendations made in our report. And NHRIs have an important role to play in ensuring compliance with international law in general, for instance, by calling greater attention to an investment in women and girls' sexual and reproductive health priorities.
PDHG, in partnership with the United Nations Population Fund, UNFPA, published a country assessment on sexual and reproductive health rights. This report provided an overview of 5 key areas: maternal and child health, family planning, reproduction health education, HIV and sexual health, and gender-based violence. First, maternal and child health. Maternal deaths remain a challenge despite most deliveries being attended by skilled personnel. Women and mothers have difficulty assessing adequate antenatal and postnatal care, and children are still dying from preventable causes. Inequalities in access to maternal health care are evident nationwide, with rural women and girls facing challenges in accessing sexual and reproductive health services. Key recommendation: strengthen measures to ensure that all women, including young women and rural women, have timely access to quality antenatal and postnatal care, emergency obstetric and newborn care in line with the Emergency Obstetric and Newborn Care Plan of Action. 2, family planning. Difficulty in accessing contraceptive information and services, especially adolescents and unmarried people, contribute to women having unwanted pregnancies and large numbers of babies. Adolescents' pregnancies lead to early marriages and contributing to higher rates of death and disability for adolescent mothers and their children. Abortion is restricted to protection of the life of the mother. Key recommendation: provide to all Timorese people access to family planning services and effective modern contraception to reduce the incidence of unintended pregnancies and unsafe abortions in Timor-Leste. 3, reproductive health education. People, particularly young people in Timor-Leste, have a poor understanding of sexual and reproductive health, including knowledge about modern contraceptive methods, how to get pregnant, sexually transmitted infection, and HIV prevention. The lack of sexual and reproductive health education has contributed to the incidence of unwanted pregnancies, early marriage, and other consequences. While Timorese law and policy environment is broadly supportive of reproductive health education, cultural taboo make it difficult to implement. The prevailing cultural view is that young unmarried people should abstain from sexual relations and should not be taught about sexual and reproductive health. Key recommendation: ensure universal access to comprehensive sexuality education, both in school and out of school, that is age appropriate, unbiased, scientifically proven, and gender sensitive. 4, HIV and sexual health. While Timor-Leste is a low prevalence country for HIV, with 1711 cases identified up to 2017, there are concerns that transmission is occurring in the general population, which requires close monitoring. STIs, on the other hand, are very high, with rates of 16.1% in clients of sex workers. The population generally has a low knowledge of and access to STI and HIV prevention, testing, and treatment. Young people have especially low levels of knowledge about comprehensive methods of preventing HIV and STI transmission and are not specifically targeted by information campaigns. Key recommendation: increase HIV and STI prevention through non-discriminatory, comprehensive, voluntary counseling, testing, and treatment for the most at-risk population. Gender-based violence. Gender-based violence is widespread in Timor-Leste. Intimate partner violence is one of the most pervasive types of violence, but there is also prevalence of sexual violence, child abuse, and trauma. Particularly vulnerable groups include lesbian, gay, bisexual, transgender people, and people living with disabilities. Factors contributing to the high incidence of gender-based violence included unequal gender norms, attitudes that justify violence, and other manifestations of male dominance over women. Key recommendations: strengthen awareness raising and educational activities targeted at men and women, traditional leaders, healthcare, and social workers, with support from civil society to eliminate prejudices related to violence against women.
In 2017, the Samoa Office of the Ombudsman, National Human Rights Institution, conducted its first ever inquiry, which looked into violence in the family setting, with a special focus on women, girls, and the impact of violence on the upbringing of children. Preparing for and conducting the inquiry took 2 years. The inquiry consulted all corners of Samoa, various stakeholders and agencies, government, NGOs, community and community leaders, church, donor partners, experts, and most especially survivors and victims and perpetrators of violence. A report was produced soon after in 2018. There were 39 recommendations. All these recommendations either have specific mention or has some link or relation to sexual and reproductive health rights. So the first one is our engagement with parliamentarians. So the inquiry found that there was a lack of government commitment and approach through inadequate allocation of resources, support, and lack of coordination to address family violence. So there was recommendation 18, which provided that there should be universal parliamentary support for addressing family violence. And this is through the acceptance and endorsement of the inquiry recommendations by all parliamentarians. So last year, the office carried out its first workshop with its parliamentarians, which was supported by UNFPA. The theme of the workshop was strengthening partnership and promoting proactive engagement with parliamentarians. This was the first time the office had conducted a dialogue of this kind with our parliamentarians. Activity 2 is with some of our ministry agencies. So I've selected just one of them. And this is specifically with our Ministry of Education. Now, one of the inquiry findings noted that a general absence of sexual education and healthy relationships education in schools is a contributing factor to family violence in Samoa. So the need for a comprehensive sexual and healthy relationship education curriculum, taking into account human rights-based approach and be underpinned by Christian and Samoan values for Samoa, was commonly identified throughout the inquiry. And the last one is with regards to the community. Now, this is specifically with, it's a village community-based project. We call this the Village Family Safety Committee pilot project. In Samoa, the Council of Chiefs, or known as the Village Fono, has a critical role to play in the early prevention of family violence. They are expressly responsible for promoting social coherence and harmony. So this is provided in law. Yet the inquiry found that there is little to no evidence of any proactive prevention of family violence, and the prevalence of chief perpetrators is a significant barrier to it. So in order to meet its responsibilities in relation to social coherence and harmony, the Village Fono, or the Council of Chiefs, needs to establish a credible mechanism for preventing and protecting against family violence.
Now, I'd like to move to the speakers list, and I would like to warmly welcome and invite Chairperson Nasima Begum from the Bangladesh Human Rights Commission to please make your 2-minute presentation. Thank you, Chair.
Significant progress has been made to promote gender equality, but in many areas, violence against women and girls remaining a big challenge in Bangladesh. During the pandemic, the world witnessed a shadow pandemic of rising gender-based violence. It has been devastating during COVID-19, when access to help is more limited. Despite many achievements on gender equality and empowerment of women, the situation is not different in Bangladesh. On this context, the National Human Rights Commission of Bangladesh have taken a groundbreaking initiative of conducting a national inquiry into violence against women and girls with a focus on rape. I trust the report of National Inquiry will reveal with some critical findings to address the worst form of human rights violation from a systematic perspective. Since we formed the National Inquiry Committee, we have undertaken consultation with Asia Pacific Forum and with the help of APA territory in Samoa and Afghanistan, all of these have experienced or conducted national inquiries.
The CHR conducted two national inquiries on reproductive health. The first one was a general one. The second one, the more recent one, it actually zeroed in on women with disabilities and their reproductive health rights. And we wanted to be able to surface the specific barriers experienced by Filipino women with disabilities and sought to document individual and systemic barriers to women with disabilities access to sexual and reproductive health information services and commodities. We also wanted to document the barriers and problems experienced by service providers in providing reproductive health information services and commodities to women with disabilities. And in this context, we were able to also amplify the lived experience, the stories of women with disabilities on the ground. We were able to document how men and family members exercise control over the sexuality and reproductive health of women with disabilities, which is really an affront to their autonomy and self-determination.
Our commission is focusing on the phenomena that discrimination on women comes in combination with other structural discriminations. The commission hopes to do our parts in fulfilling the recommendation stated on women and girls' sexual and reproductive health rights in crisis. I would like to introduce some of the works that have been done by the commission. First of all, in 2019, the commission have filed a recommendation to the Constitutional Court of Korea that penalizing women who had an abortion is an infringement of women's rights for self-determination, health, life, and reproduction. Often receiving the recommendation, the Constitutional Court concluded that clause do not correspond with the Constitution and requested amendment. The government then made partial amendment to Draft 2 Criminal Act and partial amendment to Draft 2 Mother and Child Health Act, but which still maintained criminal penalty for those who underwent abortion. The commission consequently commented to the chairman to the National Assembly that it is desirable to criminalize abortion.
As far as reproductive rights or sexual rights for the women is concerned, they are very, very much restricted. That is the fact of the story. And there needs to be looked into, revisited with the change scenario where the women is an independent. I mean, it's not the only marriage where the children are born. The women can herself have a child.
Today, you've given us examples of a lot of good practices, and that information is also very useful for us because that's the kind of information that we can share with other governments during country visits as well as other forms of engagement.